In this video, you can learn about some important inherited disorders of amino acid metabolism like phenylketonuria, alkaptonuria, and maple syrup urine disease. Let's start with phenylketonuria. It is an autosomal recessive disorder characterized by an increase in the concentration of phenylalanine and its byproducts in the body fluids and by severe intellectual disability if untreated in infancy. Conversion of phenylalanine to tyrosine is defective in phenylketonuria and usually occurs due to a defect in phenylalanine hydroxylase. The accumulation of phenylalanine inhibits the transport of other amino acids required for protein or neurotransmitter synthesis, reduces synthesis, and increases the degradation of myelin, and leads to inadequate formation of norepinephrine and serotonin. Phenylalanine is a competitive inhibitor of tyrosine, a key enzyme in the pathway of melanin synthesis, resulting in hypopigmentation of hair and skin. Untreated children with classic phenylketonuria are normal at birth but fail to attain early developmental milestones, develop microcephaly, and demonstrate progressive impairment of cerebral function. Hyperactivity, seizures, and severe intellectual disability are major clinical problems later in life. EEG abnormalities, mousy odor of skin, hair, and urine, due to phenylacetate accumulation, and a tendency to develop hypopigmentation, compared to the family background, and eczema complete the devastating clinical picture. In contrast, affected children who are detected and treated at birth show none of these abnormalities. Diagnosis is made through newborn screening. This includes the determination of blood phenylalanine levels. Abnormal values are confirmed using quantitative analysis of plasma amino acids. Treatment of phenylketonuria. To prevent intellectual disability, diagnosis and initiation of dietary treatment of classic phenylketonuria must occur before the child is 2 weeks of age. Treatment consists of a special diet low in phenylalanine and supplemented with tyrosine since tyrosine becomes an essential amino acid in phenylalanine deficiency. With therapy, plasma phenylalanine concentration should be maintained between 120 and 360 micromoles per liter. The dietary restriction should be continued and monitored indefinitely. Oral tetrahydrobiopterin, 5 to 20 mg per kg per day, an essential cofactor of phenylalanine hydroxylase, can reduce phenylalanine levels in some patients with phenylketonuria in conjunction with low-protein diet. Pegvaliase is a pegylated form of phenylalanine ammonilyase, a bacterial enzyme that converts phenylalanine to transenamic acid and ammonia can also be used. Women with phenylketonuria can become pregnant by continuing lifelong phenylalanine-restricted diets and strict phenylalanine restriction 2 months prior to conception and throughout pregnancy to reduce pregnancy risks. The next disorder that I'm going to discuss is alkaptonuria. It is an autosomal recessive disorder of tyrosine metabolism. There is a deficiency of homogentessic acid dioxygenase which blocks homogentessic acid metabolism, preventing the conversion of tyrosine to fumarate. Homogentessic acid accumulates in the body and is excreted in the urine, imparting black color to urine if allowed to sit and undergo oxidation. In patients with alkaptonuria, the retained homogentessic acids selectively bind to collagen in the connective tissues, tendons, and cartilage. This leads to ochronosis, a blue-black pigmentation that is most evident in the ears, nose, and cheeks, and ochronotic arthropathy, which typically manifests in adulthood. Also there may be the involvement of cardiac valve and coronary artery calcification. The diagnosis and evaluation of alkaptonuria can be established based on the severity scoring system. Alkaptonuria Severity Score Index, ACUSI, is a clinical scoring system of an objective measurement of severity. It is based on a quantitative validated multidisciplinary assessment. Laboratory diagnosis of alkaptonuria includes the urine test for homogentessic acid, HGA, is the gold standard test to diagnose alkaptonuria. The amount of homogentessic acid in the 24-hour urine is detected via gas chromatography mass spectrometry, GCMS, analysis. The amount of HGA excreted each day in patients with alkaptonuria is usually between 1 and 8 grams. The change in urine color is nonspecific. Molecular genetic testing can identify the biallelic abnormalities in homogentessic acid dioxygenase and other mutations that can help in family counseling. Treatment of alkaptonuria. The management of alkaptonuria remains palliative, which includes pain control, physiotherapy, and joint surgery. Additionally, the main focus of the treatment is to reduce the deposition of homogentessic acid. Commonly recommended therapy involves ascorbic acid, which is known as vitamin C due to the effect on reducing the conversion of homogentisic acid to benzoquinone acetic acid by oxidation. However, it does not affect the urinary excretion of homogentisic acid. A low-protein diet can reduce tyrosine load and reduce the severity of the disease, but compliance with dietary requirements is not easy. Efficacy is unproven. Many studies have suggested that nitisinone, a trichotone herbicide, has a significant impact on the treatment of alkaptonuria. Nitisinone inhibits the conversion of tyrosine to homogentisic acid. Also, nitisinone therapy, 2 mg per day, has shown to produce a reduction in urinary and plasma homogentisic acid larger than 95%. This disorder does not seem to affect life expectancy. However, the significant impact is on the patient's quality of life. Let's learn the final disorder of this video, which is maple syrup urine disease, MSUD. It is an autosomal recessive inborn error of metabolism due to branched-chain alpha-keto acid dehydrogenase complex, BCKDC, deficiency. This enzyme normally allows for the breakdown of leucine, isoleucine, and valine into substrates for entry into the TCA cycle. BCKDC deficiency is neurotoxic primarily due to elevated levels of leucine. Infants present in the first few days of life with progressive irritability, poor feeding, lethargy, and increased muscle tone. The urine characteristically has a sweet, maple syrup odor. This burnt maple sugar smell is more noticeable in a diaper after the urine has dried. In infants with non-classic maple syrup urine disease, i.e., intermediate maple syrup urine disease, intermittent maple syrup urine disease, symptoms tend to be milder and may not be readily apparent early in the course. Diagnosis of maple syrup urine disease is made through neonatal screening. The test is performed within 24 to 48 hours following birth. Newborn screening for maple syrup urine disease is performed with tandem mass spectrometry using concentrations of leucine and isoleucine and the Fisher ratio, branched-chain amino acids /phenylalanine and tyrosine, as diagnostic measures. Plasma amino acids, PAA, testing should be performed to assess for elevated levels of branched-chain amino acids, BCAAs, and to detect L-alloisoleucine, derived from L-isoleucine. The detection of L-alloisoleucine, also termed alloisoleucine, is diagnostic for maple syrup urine disease. BCKD enzyme activity can be measured in lymphocytes, cultured fibroblasts, or both, although this test is not required for diagnosis. Molecular testing confirmation should be pursued in all patients diagnosed with maple syrup urine disease to confirm the diagnosis, to provide additional information about prognosis, to provide the knowledge for in-depth genetic counseling for the family, and to provide criteria for prenatal testing. Treatment of maple syrup urine disease. The two main approaches to the treatment of maple syrup urine disease, MSUD, include 1. Long-term daily dietary management and 2. Treatment of episodes of acute metabolic decompensation. The mainstay of treatment is dietary restriction of branched-chain amino acids, BCAAs. Aggressively treat episodes of metabolic decompensation. Initiate intravenous glucose infusions, 5 to 8 mg/kg/min for infants, as rapidly as possible. Insulin infusions may be added to promote anabolism. Stop intake of BCAAs but resume intake as soon as plasma BCAAs normalize. Whenever possible, continue additional dietary support, including lipids and/or nutrition free of BCAAs. In rare circumstances, hemodialysis or peritoneal dialysis is required to remove BCAAs and keto acids. Orthotopic liver transplantation performed at an experienced medical center has changed the outlook for patients with classic maple syrup urine disease, who are frequently challenged with episodes of metabolic decompensation. Thanks for watching. I hope it was useful and helpful to you. Stay tuned for the next video. Thank you.